Well, good afternoon, everyone. Welcome into December of 2021, the final month of the year. And this is our first Friday, December 3rd, here in the United States, the afternoon, but maybe it's the next day already for my friend Chris and Jody down under. So, wherever you are, wherever this finds you, greetings from the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation. I'm Mike Ackerman, genetic cardiologist here at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and its complementary Winland Smith Rice Sudden Death Genomics Laboratory. But here today, I'm with you as I am almost every Friday, now every other Friday, on behalf of Alice Laura, our CEO of the SADS Foundation, where I've had the privilege of serving alongside her as president of the board for the past 15 years. And we've been together a lot throughout this pandemic. We're on SADS Live episode number 79 today. And so I hope this finds you well. And I'm looking forward to your questions. Get them ready. Start typing them in, and I'll glance off to the side to read them. And I will take them in order as I do. And I will be stimulated, I'm sure, as I always am, because your questions are amazing. Yes, we are still in this pandemic. When will it end? Who knows? But don't fear at all. Remember, I don't see if you can see it, faith over fear, whether we have to deal with Delta or Omicron or the next Greek alphabet designation of the SARS-CoV-2 virus and its latest mutated strain. Don't worry about this. We can do this. We are doing this. Do all the right things. Yes, the numbers are overwhelming. 264 million cases of SARS-CoV-2 infection worldwide, over 5 million deaths. That's a huge number. And each of those deaths, there's a tragedy for that family of those left behind. Over 8 billion doses of vaccine have been administered. In the United States, where many of you are joining us from, almost 49 million cases, 785,916 deaths, 33,000 deaths in the last 30 days, so still over 1,000 deaths a day. And again, grieve for those families. But still to date, we are less than 0.1% of the globe has been killed by SARS-CoV-2 mediated COVID-19. 99.9% of us are alive. So we always have to decide which do we do, glass half full, glass half empty. And I encourage all of you, please do not panic about the Omicron, no matter what sensationalization the media is trying to do and sometimes does do, try to gin it up and spin it up. It's an important issue. We don't know a lot about it yet, but we know what we know and we know what we can do. Yep, still do it. Wash my hands when I can. Yep, I still do it. I mask up when I can and as I can. You will not see me wearing this when I'm driving a car, though. Sorry. And you will not see me wearing this when I'm walking down the street or taking my dog for a walk. Doesn't make sense to me, but that's just me. Indoors at the clinic, of course. So do what you can. And if you are time and age eligible to get boosted, get boosted. I'm boosted. And if you have not even had your first and second of the Pfizer or Moderna or the single J&J, get it. It's a great time to do it. Get it done before the family gathering. It certainly looks like it may not prevent being infected by the Omicron SARS-CoV-2 variant, but it certainly is looking like it prevents serious infection. Still, a lot of good news for our families with genetic heart disease. There is not a single shred of evidence that getting infected with the SARS-CoV-2 virus of any strain is agitating to your long QT heart, your Cpvt heart, your ARVC heart, your Brugada heart. We have not seen a single hint of evidence that the long QT triggered events during the 2 years of the COVID-19 pandemic are any different than the years prior. So good news. The virus is not going to trigger your long QT CPVT substrate into misbehavior. Of course, we still would like to not get the virus if we can, but I think ultimately we probably all are. I'm infection-free so far. I'm boosted, but I could get infected. So do what we can, and please do not worry or fear. Be anxious for nothing, but in everything, by prayer and supplication, let your requests be made known to the Lord. Well, amen. Your questions, let's look at them. On December 3rd, 2021, from Freyd, and hello there. What's the recommendation for a 6-year-old male borderline type 1 regarding the COVID vaccine? Great question. It doesn't matter whether you're borderline type 1, WOW type 1, type 2, type 3, type 17. If you are age eligible for the vaccine, the Center of Disease Control and in the United States, most world authorities, and the Mayo Clinic does recommend the vaccination for the approved ages. And I would have no reason, no data to counter that. So I certainly would have your son vaccinated if he is age eligible, and it really has nothing to do with what his or her long QT status is. Alexa is asking, what recommendation would you give an individual with a GPDL1 variant diagnosed with short-coupled VF, a Brugada phenotype, but no Brugada signs on ECG? Woo! Just the second one and already a tough one. So that gene, GPDL1, was actually discovered by my friend and colleague, Dr. Barry London. Now he's chair down at University of Iowa. Large linkage analysis implicated it in Brugada syndrome as a gene whose protein then affects the amount of sodium channel. And look, the evidence looked good, very good. We participated with Dr. London in that. And then we've published separate papers about GPD1L in infant death. Now, fast forward to present time, one of the NIH resources, ClinGen, for Clinical Genome Resource Center, they analyzed all of the evidence and they said, we are not totally convinced that GPD1L is a bona fide Brugada syndrome susceptibility gene. So I think that gene, whether you do have it or don't have it, honestly, it doesn't matter. What matters is what is the ECG appearance, and you mentioned short-coupled VF. And so there, your team of physicians is addressing that short-coupled VF and looking at what treatments, if any, they should do, or just watch and wait to see if there's ever a VF terminating ICD shock, to see if whether or not that trigger mechanism of the PVC, premature ventricular contraction, can and should be ablated, whether or not there's a possible role of a medicine like quinidine. And so I'm thinking about all of those things, and the GPDL1 or GPD1L status doesn't really matter. Hello, Dana. Great to see you in Ireland, and Erica from Germany. College, I had to take German, and I still remember the first sentence that we learned for German for chemistry majors. I'm not sure why. Was machst du heute Abend? Ins Kino? So that was, what are you doing tonight? Going to a movie. So greetings to you. Michelle's asking, oh, I missed it. Oh, I know, Sophie. It's a good one. I have to get her on here. When will the session be about supplements and long QT syndrome? Okay. I have failed on this. I promised it and I have not delivered. I am working on the person to join us. And how about I promise that we'll do it January, February, or March of 2022. So that gives me 6 opportunities to get this nailed down. So I'll have Aaron on our dream team of the SADS Foundation and Anna hold me to it to find somebody. So great reminder, Sophie. Michelle is asking, When will we be able to view our QTC results on the KardiaMobile app? And how will we know when it becomes available? So full disclosure, this gadget, KardiaMobile, from the company called AliveCore, when that QTC feature gets turned on to it, that will be because it's received FDA clearance to do so. And at that point, that knowledge or that logic that will enable the QTC to be turned on, that was developed in part by myself and other co-inventors here at Mayo Clinic. So I know a lot about it. We're very interested in it, but I guess if that's a conflict of interest, I'm sharing that with you all. Now, we turned it all in to the FDA. They reviewed it. They sent back comments, and we're responding to those comments and resubmitting it. So I'm quite hopeful now, based upon the comments, which were very positive from the Food and Drug Administration, that we should hopefully get green light go for AliveCore to turn on the feature in first quarter of 2022. I suspect when that happens, that won't be a secret. So you'll learn about that at that time. But until then, you're still able to do your recording, save it the PDF, send it to people. And I'm tracking patients all over the globe right now where they're sending in a PDF for me to just take a peek at the QTC because we've adjusted their mixillatine dose, or because their weight has changed significantly for the infant and so forth. And so it's going to get a lot easier. Then I won't have to do the first line measurement. So hang in there, Michelle. I'm hanging in there, but my best guess is first quarter 2022. Alice is from Natasha. Oh, I'm sorry, Natasha. Sharing, and I read it in real time. My husband died of cardiac arrest. His genetic testing from Invitae, one of the companies, and we've had that company on the program before, revealed 2 variants of uncertain significance. One for long QT4, so that would be the ankyrin B gene, and one for ARVC, and I'm not sure which gene. The genetic counselor is not recommending genetic testing for the children. Can you speak to this? Showed up on ANK2 and RYR2. It's a great question, Natasha. And again, I'm sorry about your husband's death. It really would take reviewing the circumstances of his cardiac arrest, and then for somebody like myself, a genetic cardiologist, or to stare at those variants and say, okay, I know what Invitae called them, a variant of uncertain significance. And when they call it that, the genetic counselors throughout the globe have been largely instructed that you do not test others for that variant, that uncertain variant. I respectfully disagree, because I think testing other family members, especially those who show something, can be very helpful in adjudicating that variant, determining whether or not we agree with the company's classification or whether it should be upgraded, promoted to a disease causative variant, or demoted to nothing relevant at all. So I try to get all of the data that I can, but when it starts with a sudden cardiac arrest, I do see what the genetic counselor is getting at, being hesitant to test your children. The children should be clinically evaluated in our program when there's a sudden cardiac arrest or death of a loved one. That immediate circle of first-degree relatives, that loved one's siblings, that loved one's children, they need to see a cardiologist. They need to do a round of testing. That for our program, that includes an ECG, a Holter, a stress test, and an echo. And then we wait after that, study those, and decide, do we do any additional testing? Even more important in studying the living is to say, did your husband have an autopsy? Was that autopsy conducted, or was the heart examined by a cardiac pathologist, so that we can really be as confident as we can whether the heart was clean and not involved, or whether something suspicious was found. So great one. And Michelle, Alexa, so Alexa's updating me. Now I have to remember about the short coupled VF. So that's too many shocks, 9 shocks, 2 electrical storms. All I can say is, Alexa, you really need to have you and the heart rhythm specialist deciding whether they're satisfied with flecainide and metoprolol as the treatment strategy, whether it should be shifted to something like quinidine, or whether there should be a study done to see, forget about the GPD1L status, whether there should be consideration given to doing an EP study with the possibility of ablation. Michelle is asking, hi, Michelle, any research or evidence connecting long QT syndrome and AV block? Husband has LQT2, suffered an AV block, has a pacemaker. Whether the conditions are related, youngest son has long QT. Good question. I would say right now the evidence to link long QT syndrome type 1, 2, or 3 to concomitant AV block is almost zero. I have over 1,500 patients. Some of them are you out there with long QT syndrome, and we almost never see AV block. Rarely do we see first degree AV conduction delay, but higher grades of AV block, that is almost never. So I would not be anticipating that for your youngest son. And it is certainly possible that your husband is dealing with 2 independent things, the LQT2 substrate, and oh, by the way, now some age-dependent AV block. I'm in good pace. I'm keeping up with you. I'm only 4 behind, so start adding some more. Chris, hi Chris. Oh, great. I love this one. What is the connection between LQT2 and epilepsy? He's on an anti-seizure med due to positive readings from the brain scan. Cardiologist is convinced that the seizures, however, were due to the long QT and are now controlled by Nadolol and the defibrillator. My neurologist strongly thinks I need to stay on my seizure meds. Ooh, that's a good one, Chris. So this is a story that we know really well. We participated a lot in the discovery of this connection and observation. My good friend, Chris Samsarian from Down Under, they had similar observations at the similar time. So let's start with what we know. So LQT2 is due to loss of function mutations in the KCNH2 encoded Kv11.1 potassium channel. So that specific potassium channel we used to think was predominantly exclusively expressed in the heart. We now know that that's not entirely true, that same protein is also present in the pancreas, and it's also present in the brain, particularly the hippocampus. So that's one observation. The second observation we made and published years ago now was we asked the question, is there a difference in labeling of seizures based upon what your genetic type? So patients who get called having seizures, misdiagnosed as having epilepsy, does that happen with one genetic type more than the other? And the answer is yes, it does, LQT2. And so when we observe that, we then reason that, well, maybe that could mean 2 things. One, that LQT2 patients, when their LQT2 heart does its rhythm thing, because of the brain thing, the brain might be more quickly irritable and go into seizures when the heart is doing its thing and not delivering blood to the head. Or we reasoned that some of these patients with LQT2 could be having truly epileptogenic seizure activity, brain seizure activity, while the heart rhythm is completely bump, 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 normal. And both of those are probably true. We have seen a higher frequency of seizures. In fact, we have patients with LQT2 where we have proven the presence of temporal lobe epilepsy, for which we've even done epilepsy surgery. And then the epilepsy has stopped, come off of the epilepsy medicine, and then just navigating the long QT2 heart. So what we have not proved yet is that the KCNH2 mutation by itself does epilepsy. So that link has not quite been proven, but we've connected a lot of the dots. And so the key for you, Chris, and your team is to try to decide which organ is to blame. So if the EEG, the brain waveform activity, is abnormal, then the neurologist is probably spot on. And yes, we need to treat your LQT2 with the Nadolol, but that seizure may not have been the result of your long QT heart misbehaving. And the only way one would prove that and know that is if you were to have a loop recorder to record the rhythm continuously, or a defibrillator placed, and then when you did the seizing thing, was the heart in perfect rhythm or was it in the LQT2 rhythm? That's how you prove it. And so I would just be patient with both. Both the brain doctor and the heart doctor are trying to take the best care of both of those organs, and wish you well with that. I hope that was helpful. Teacher or Mary, I'm not sure if the order of the names, but what's my recommendation for a 6-year-old boy with long QT syndrome? It depends. It depends on what kind of long QT syndrome, LQT 1, 2, or 3, something else. It depends on how that long QT syndrome was discovered. No symptoms, family testing. Now we flag the 6-year-old, went in for a regular ECG for whatever reason, and it got caught. So was it incidentally discovered, or was it because the 6-year-old was playing in the playground and collapsed suddenly and had to get resuscitated by first responders? So much of it depends on the portal of entry. And then what's the QTC look like? What is your QT number? I love for my long QT patients to know their QTC, just like a diabetic would know his or her sugar number, his or her hemoglobin A1C, and so forth, because I can know a lot by knowing the QTC, and I want you to know a lot because that QTC is a good meter of what risk category are we starting to think about you in. QTC above 600, spooky. Better have everything dialed in perfectly for protection. QTC normal, less than 440, but you own the mutation. Okay, yeah, you own the mutation. Your risk is super low. So a lot of things that we've looked. Oh, somebody, I guess I got busted by Erica. She said I skipped something. And now let's see. Oh, I see. I scrolled back up. Sorry. Erica is asking about any news about the correlation between RYR2 and ANK2. Is Cpvt different if you have both mutations? So there, I would say RYR2 encodes the ryanodine receptor, clearly causes Cpvt. In fact, it causes 2/3 of all Cpvt. ANK2, there's no connection directly between those two genes as one goes with the other. ANK2 encodes a protein called ankyrin B. That gene was implicated in something that was called type 4 long QT syndrome. Now, probably not LQT4, doesn't really deserve that. At best deserves to be its own entity called ankyrin B syndrome. And ankyrin B syndrome has some features that can overlap with the more common genetic heart syndromes. But the more likely thing is that one of the genes matters and the other probably doesn't. I doubt you have true pathogenic mutations in both RYR2 and ANK2. ANK2 has become problematic because there's a lot of genetic variation in that gene, and most of it doesn't cause a problem. So sorry I missed you, Erica. Now I see that everybody's keeping me on my toes, so I better get back in order. Okay, I did teacher. Corrine is LQT2, diagnosed in 2008. Her defibrillator lead broke in 2010. That's a bummer. Sorry to hear that. Now the defibrillator lead has an impedance problem, wants to shut it off. lead, or should I have them extracted with new defibrillator lead? Well, that's, I like the question. I'm sorry it's your question and that you're going through it and enduring it. LQT2 in women is a combination that I respect a lot. LQT2 in women is the subcategory where I probably use more defibrillators than in any other combination. So as you know, I don't like to use ICDs. I've said many, many times that most people with long QT syndrome do not need an ICD and should not receive an ICD. Where I reserve the ICD for is bad long QT syndrome. Already tried to kill you, sudden cardiac arrest as the portal of entry. We better be really confident in non-defibrillator strategies. Otherwise, we're going to be giving a prophylactic or a secondary protection ICD. Now, I do implant LQT2 women who have never had a symptom if I don't like what I've sized up as the weather forecast. So where is the long QT2 mutation? What is the ECG? Is your QTC every time I get an ECG above 500 milliseconds? If so, I used to be very aggressive and add the ICD. However, in the last 5 years, we have started to use mexiletine in LQT2 with really great effect. Have published our experience with that with Peter Schwartz as well. And so now I think I've gotten slower than what I once was in terms of LQT2 women, QTC above 500 must have an ICD. Now I've backed off to where I think in that scenario, we could be slower before committing that person to a mandatory preemptive or prophylactic ICD. So in your case, at a certain point when now the complication package of the defibrillator strategy is starting to tilt button, then that would make me say, should we reassess what our treatment options are? And Durham, Corrine, is just updating. Never been shocked, scared to shut it off. Your sister tragically died before getting diagnosed. So there I would just say, Corrine, that we would be more than delighted. It would be a privilege to care for you and work through that. You need to be connected to your A team and be very comfortable and confident in deliberating what's the best next step in terms of navigating your treatment program. Jennifer's asking, can I also comment on a correlation between Cpvt and seizures? After several episodes of syncope with convulsions, she was diagnosed with seizures and a positive EEG and started with anti-seizure meds in June. In November, she was diagnosed with Cpvt after a stress test gene test. So there, Jennifer, I would say there's not the equivalent level of evidence to put together a link with seizures coming from the brain. Now, it turns out that the ryanodine receptor is also expressed in the brain. And it's therefore possible that there could be some abnormalities in intracellular calcium handling in the neurons of the brain that could be epilepsy or seizure producing. It has not been proven. What we have shown, and Arthur Wilde in Amsterdam led this collaborative study, is that there is a signal of learning disabilities and things in the autism spectrum, I would say, with Cpvt from ryanodine receptor mutations. The signal's not a strong one, but it's about a 10% signal, meaning if we look across all of our Cpvt patients, about 10% have some measurable level of learning disability, learning impairment, and so forth. So again, that would argue that there is a contribution of the ryanodine receptor centrally, neurologically in the brain. But the other thing we know of why it could be called seizures is when a CPVT person's heart goes into the CPVT danger rhythm, they are more quick to probably show convulsions, head to toe seizure like activity than from other drivers or other substrates. So still a lot to be determined. Teacher's update. If dad has long QT and he is 40 already and has never had a problem, never had to be treated, what are the chances of his children who are diagnosed having complications? That's a super important question of the day, because there are certain genetic heart diseases where how it is playing out in the family is informative, meaning a tragedy in dad or uncle or aunt is now a personal risk factor for Johnny, Sally, Susie. So that genetic heart condition where we know that connection, where the family story matters, is one called Hypertrophic Cardiomyopathy, or HCM. There's good news in long QT, Brugada syndrome, CPVT, is that it does not look like family story matters, meaning how it behaved in somebody else in the family has very little predictive value in how it's going to behave in you. So that could either be viewed as good news or bad news. When is it good news? Well, in a family story where there's been a lot of tragedies, those tragedies are tragic, but they are not of forecast value for the patient in front of me. On the flip side, the story could be boring, nothing in the family, no symptoms, no nothing. And that could lull people to sleep thinking it's nothing. And then in the next person, the next generation or whatever, in that new owner of that family's variant, it could be quite obvious and quite impressive and quite aggressive. So every family member who owns the long QT variant, owns the CPVT variant, needs to be studied on their own for us to decide, what do we think about its electrical behavior in that owner, largely independent on what it's done or how it's done it in any other person in the family tree who's possessed that variant. Karine just commenting, I think Karine has so many that I'm, yep, LQT2, that QTC number was 470. That's encouraging. That gives us some wiggle room to explore every option and decide, does it make sense to persist with a defibrillator strategy, or is it time in your life to consider to see and learn what the other treatment alternatives are? And Lene, thanks so much for those kind words, and back to you as well. You're one of the very special ones. Emily is asking, asymptomatic Brugada, 43-year-old female, any reason to have a stress test done? Honest answer is no, but I do them. So I like the stress test as part of the overarching evaluation. Its contribution in Brugada syndrome risk assessment is minimal, very low. And so if I were forced to cancel one of my tests in an asymptomatic 43-year-old female for their annual Brugada, or their every other year or every third year Brugada drill, I would probably be dropping the stress test in that setting. Petra from Europe, Slovenia. Oh, I've never been there. I would love that someday. Slovenia. 12-year-old, little bit long for the question, but this might end up being one of our last ones. Let's see how we do. 12-year-old daughter, alpine skiing until January, sports exam mandatory at age 12, borderline extended QT, did genetics and it's negative, yay. Also had a stress test, negative, and the 24-hour Holter at night. Oh, we don't. So then it broke off, but I think I get the point. So this is a really important scenario, Petra, because my dear friend Peter Schwartz and Leah Crotty in Italy drew attention to this. We actually had this observation, but they beat us. And what they found, and the point I'm making is, we are starting to see that in athletes having their obligatory mandatory ECGs are getting the QT flag thrown. And yet when we look at everything, we're finding nothing. And Peter Schwartz showed and published a few months ago in Circulation this notion that exercise training may be creating what I would call an acquired prolonged QT phenotype. Just like a certain drug can give you drug-induced QT prolongation, aerobic exercise training can modify the heart to cause the QT interval of that heart to shift to the right. And then if you detrain those athletes, the QTC shifts back into the normal distribution range. And so when our athletes are getting flagged, and we did this drill just 2 hours ago in an elite swimmer, when we see this phenomenon with that portal of entry, athlete mandatory screening ECG, now the QT flag is thrown, we have the awareness to not be so quick to commit a lifelong diagnosis of long QT syndrome to that person. So I think your team in Slovenia is going to gradually need to see if we can rewind that consideration, lift up the penalty flag, and say, after further review, there's not enough evidence, and the penalty has been lifted. The call on the field has been reversed. Football analogy, sorry. And the Holter phenomenon, what it recorded, doesn't mean a thing, doesn't make me concerned at all. I think far more important is the negative genetic test, which by itself, a negative genetic test for long QT syndrome rules out 80% of all long QT syndrome. Kareen's, how can you reach me? The SADS Foundation can help you with that, Kareen. Jennifer, you're welcome on that. And I think we've got that. We're getting there. Stephanie, will long QT be curable through gene therapy within maybe the next 30 years? Yes. It could be much faster than that, and we will know in the next 3 years whether it's going to be faster. We're very excited about this. I could talk for a long time about our efforts in providing a gene therapy solution where we're going to be testing early 2022 the gene therapy that we've developed at Mayo Clinic in rabbits that have been engineered to have either type 1 long QT syndrome, LQT1, or type 2 long QT syndrome, LQT2. And if we can cure those wascal rabbits next year, we could see first in-person trials within 2 to 3 years from today. So we need things to happen. We need things to work. If they don't work, then what we've created won't work. But a lot of people are applying a lot of energy to come up with novel solutions to long QT syndrome and other genetic heart conditions. Well, we'll save the next two, or the two that I missed, for the next time. And until next time, I've got a surprise for you about next time. We thought 40 minutes ago that this was going to be our last SADS live session of 2021, but I knew that this would be too long and I would be missing you. And so we're going to do this again 3 weeks from today on Christmas Eve. A great time to celebrate life, to celebrate you all, and to be here to just say thank you one final time of 2021. So we're putting together a really special program. Hopefully we're going to have some really special people from Brittany Trees join me, and just some real feel-good stories. Maybe take a couple of questions, but it's really going to be to highlight all that we are trying to do in the SADS Foundation, all that you all are helping us do. And speaking of helping us do it, feel free, as it comes down to the end of the year, if you wanted to say your thank you in a tangible financial way, you can connect with us at the SADS Foundation, www.sads.org. And there will be a button, red, top right corner, called Donate Now. And we would be more than grateful to receive your year-end gift as your way to say thanks for what SADS is trying to do. So anything you give, everything you give will be put to great use. It will be very much appreciated. And I, for one, am very grateful to have so many of you in my life virtually, and each of you for me to have the blessed privilege to call you my very own patient. So until we're together in 3 weeks, stay well, stay corona-free, stay Omicron-free. Go get your vaccine if you haven't done so yet. If it's been more than 6 months since your 2-shot series, go get boosted. And we will do this together, and we'll do it well. And we will not fear. We do not need to shut down life. I'm going to continue to live large. I would encourage you all to do the same. See you all in 3 weeks.